Hi, this is Raphael, and here we are with Ask Me Anything for today, Saturday, what the heck date is it? The 10th of October already. Welcome. Nice to be with you. M says, "Hey team, my dad has a hiatus hernia and asked me for some exercises that are safe for him to do to strengthen his abdominal wall. I suggested planks, toe taps, leg extensions and heel taps. Do you have any advice on what would be safe for him to do for me to add to his program? Thanks in advance." Well, Em, first let's start out by talking about what a hiatus hernia is. So you have in your rib cage, it's called your thoracic cavity, and inside your thoracic cavity is your heart and your lungs, and separating your thoracic cavity from your abdominal cavity is a muscle called the diaphragm muscle, and it's a dome-shaped muscle, as in it is kind of semi-spherical, and it's bulges upwards towards the top. Well, bulges isn't the right word. It's curved, with the top being higher, or it's convex superiorly would be the anatomical way of saying it. And underneath your diaphragm, you have your various abdominal organs. And one of those that's right up the top on the left-hand side is your stomach, which is a little bag of muscle. It's a little muscular bag with 3 layers of muscle in its walls that squeeze and compress your food every which way to digest it. Now, going from your mouth to your stomach is a tube called your esophagus. And your esophagus goes down through your diaphragm, through a space in a little hole in the diaphragm called the esophageal. I'm not sure if I spelled that right, but I think there's an E in there somewhere. And it's called the esophageal hiatus. And hiatus just means space. So it's just the little gap in the diaphragm where your esophagus, your food tube, goes down from your mouth all the way down to your stomach. And the stomach itself is pretty much directly up against the diaphragm beneath the esophageal hiatus. And a hiatus hernia is where, in general, is where an organ protrudes into or out of a body cavity. And a hiatus hernia is where some part of your stomach protrudes up through the esophageal hiatus into the thoracic cavity, into your chest where your heart and lungs are. And typically this can be either asymptomatic, so no symptoms, or there can be symptoms like heartburn and reflux, basically stomach pains. But in very rare cases, it can, if too much of the stomach bulges up, it can cause problems for the heart, because it basically presses up against the heart. So it should be managed by a doctor. And in terms of exercise, I did look on Google Scholar and I found absolutely nothing, not a single study in relation to hiatus hernia and exercise in all of the history of time. So I'm really working from first principles here. But what I would say to you based on first principles is that what would plausibly cause the stomach to herniate up into the thoracic cavity would be an increase in pressure inside the abdomen, which is called intra-abdominal pressure. So intra just means within, and abdominal pressure. So basically, if there's more pressure inside the abdomen than in the thoracic cavity, well, that will push things up. And it will also push things down and it will also push things out. So intra-abdominal pressure, I would imagine, would be something that may aggravate it. And also just mechanical movements where the stomach is pressed upwards. So I'm thinking anything that increased intra-abdominal pressure might be good to give it a miss if it increases symptoms. If it doesn't increase symptoms, I probably wouldn't worry about it. But I would say, so basically what's going to increase intra-abdominal pressure is if you breath hold or brace. So basically if you go, hup, which is called the Valsalva maneuver, or if your dad does that is a maneuver that we do to increase our intra-abdominal pressure, and that helps us to brace our spine and keep things stiff. And so I'm guessing that might potentially worsen his symptoms. If it doesn't worsen his symptoms, I wouldn't worry about it, like I said. But so I would rather than avoiding certain exercises, I would more say like breathe through it. So whatever exercise you do, just breathe, don't breath hold. I would probably avoid, again, if it aggravated symptoms only, prolonged isometric contractions like hold, like planks and things like that. If it doesn't aggravate symptoms, I would say it's probably perfectly fine. And if prolonged isometric holds like planks and things do aggravate symptoms, well, you could just basically do the same movement but move in and out of it. So you could basically go, say from a down dog position to a plank to a down dog to a plank, or go, like just move in and out of it somehow, basically, so that you're not holding for a sustained period, which tends to increase intra-abdominal pressure. So that would be the first thing. The second thing, and I'm kind of just basically guessing here, but I would tend to suspect that flexion would tend to, reduce the intra-abdominal space. There's less space inside the abdomen when you flex, and that would tend to, push the organs every which way. And I would imagine, as I just, imagine the anatomy and where stuff is, I imagine that would possibly push the stomach upwards into the diaphragm. So, yeah, that may be something that aggravates symptoms. And taking a deep in-breath, again, in a flexed position, might also aggravate symptoms, because that would push the diaphragm down. As you inhale, the diaphragm descends. It is a curved muscle when it's at rest, and when it contracts, it shortens, which causes it to flatten, or in other words, descend. And so as it descends, it could conceivably, kind of squeeze past the top of the stomach. So I would say probably avoid breath holding, avoid prolonged isometrics, just move in and out of it. And I don't know about avoid flexion, but I would say particularly avoid combined flexion plus a deep inhale at the same time. But I would say be guided by symptoms. If none of that aggravates his symptoms, don't worry about it. But if any of those things aggravate his symptoms, find alternatives. So I hope that helps. I'm sorry, it's really just basically guesswork based on my understanding of the anatomy of what's going on, and there doesn't seem to be any research on exercise and hiatus hernia. What I did find is it's mostly controlled with medication and sometimes surgery. So yeah, but I'm sure you're on top of all that. OPR contacted me via a DM on Instagram. She said, "Hey Raf, I'm loving your AMAs. I can tell that so much critical thinking and reading goes behind it." Well, thank you. I've always heard my flexibility teachers and physios talk or warn me about muscle compensation, and that I have to engage or use the correct muscles so over time I don't end up with a muscle compensation related injury. Since starting at Breathe, I've heard Heath and the teachers talk about the body just knowing what muscles to use. So I'm kind of conflicted on what to believe, if muscle compo is a thing, to what extent, or if it's a load of bull. Can you shed some clarity on this topic for me? Thank you. Well, I will do my best. So muscle compensation is a thing, but it's not a thing in the way that most people think it's a thing. So compensation, just means when a body structure is unable to fully do its normal job, some other body structure can sort of take over part or all of that function. And a great example is if you injure your anterior cruciate ligament in the knee. So if you picture the knee from the side view, there's a femur bone, and I'm going to draw a super simplified version here. There's a femur bone which looks like a big kind of marrow bone. Then you've got a tibia, which is the shin bone. And then in between the tibia and the femur, running from the back of the femur to the front of the tibia, is a ligament inside the knee called the anterior cruciate ligament, or the ACL. And that ligament, the ACL, one of its primary roles is to prevent the tibia sliding forwards on the femur, or the shearing forwards would be another way of calling that. And they actually call that, let's just call it anterior shear of the tibia. And the ACL prevents that. Now, there are multiple other structures that also run in exactly the same direction as the ACL. So, for instance, you have on the outside of the knee, you have your iliotibial band, which is a tight band of fascia that runs down the outside of the thigh and inserts into the tibia and runs almost exactly parallel to the anterior cruciate ligament. And behind the thigh, you have the hamstring muscles, one of which is called semitendinosus. Semitendinosus, that's one of the inner hamstrings, and its tendon runs on the inside of the leg, almost exactly parallel with the anterior cruciate ligament and the tendon of the IT band, the insertion of the insertion of the IT band. So if your anterior cruciate ligament is injured, if there's some kind of problem with your anterior cruciate ligament, well, if it's been shown experimentally that if people just, contract their hamstrings more and also contract their tensor fascia lata more and gluteus maximus more, well, that can essentially fully compensate for the lack of structural integrity in the anterior cruciate ligament. So the tibia remains just as perfectly positioned as if the ACL was fully intact. So that's an example of muscle compensation. The muscle compensation is a real thing, and it has been documented to happen, and it's a good thing. It's redundant. We have redundant backup systems in our body. So if there's a problem with some part, other parts can take over some or all of the function of that part. That's a good thing. And that's why we see people who have a limb amputation or a severe scoliosis or, other, significant physical asymmetries, that they're often able to function, at a very high level. And we see like Usain Bolt with a scoliosis and a leg length difference, the fastest human who's ever lived, who's ever walked the planet. We see someone like Lamar Gant, who was the first human to ever deadlift 5 times his own body weight. Yes, I said that correctly, 5 times his own body weight. And the man had quite a severe scoliosis, so much so that if he hadn't have had one, he probably would have been 2 or 3 inches taller. And there is a very, very long list of people with significant asymmetries who have been able to perform at an extremely high level in many different sports because of compensation. So because, certain muscles or ligaments or bony structures were weaker on one side or, misshapen or asymmetrical or whatever, the other side or some other group of muscles, ligaments or tendons or whatever, compensated and they were able to perform. So compensation is a real thing. It's generally viewed as a good thing. When you've got a problem, you compensate for it and you can still keep going. Now, the second and probably less useful way of thinking about compensation is thinking of compensation the way that I guess most Pilates instructors would think about it, that it's a bad thing, that we're not supposed to compensate. But it's also very, I think, very muzzily defined. So the idea of, behind the second definition of compensation is that it's some kind of dysfunction, which I'm putting inverted commas around, and that there, which presupposes that there is some ideal, quote, functional state that is optimal. In which all of our muscles are equally strong and equally flexible and fire at the correct times, and our alignment is, balanced and even and centered in the joint, and everything is working in, synchrony and harmony. And that to the degree that we deviate from this sort of ideal mechanical configuration, that then we cause addition, so if one muscle's pulling harder than the other muscle, or if the joint is a little bit out of alignment, or, whatever it might be, one muscle's tighter than the other muscle, etc., that we then are pulled or pushed or whatever out of our, quote, ideal sort of mechanical configuration, and then we create compensations because one muscle has to work harder and the other muscle's not pulling its weight, and then somehow that causes an injury or wear and tear, and that has just generally not held up to evidence, that idea. So there's one particular study that I'm thinking of. So we could look at multiple lines of evidence for this. So, for example, there's there's a lot of what's called epidemiological research on this. So, for instance, looking at the relationship between sitting posture and neck pain, or shoulder posture and neck pain, or ergonomics and neck pain, all show that there's basically no relationship. The literature looking at the relationship between foot posture, pronation or supination, and running injuries, and what we find is there's basically no relationship. The literature looking at muscle firing patterns in the abdominals and spinal muscles, so the transversus abdominis, the multifidus muscle, the deep muscles of the spine and abdomen, the relationship between the timing of those muscles and whether someone has low back pain or not. And we find again and again there's basically no relationship between those things. So there's lots of sort of observational evidence, but actually, like the even higher quality evidence comes from randomized controlled trials, and there have been a few. And there's this one in particular which was done in 2017 by Azevedo et al. And it was called Movement System Impairment-Based Classification Treatment versus General Exercises for Chronic Low Back Pain, randomized controlled trial. And so what they did basically was they had 148 participants with chronic low back pain, and they were randomly assigned either into a general exercise group or a movement system impairment-based specific exercise group. And both groups had 12 physical therapy sessions, so that's in Australia what we call physiotherapy sessions, over an 8-week period. So they had 2 sessions a week for the first 4 weeks and 1 session a week for the second 4 weeks. Each treatment session was between 45 and 60 minutes and was supervised by trained physiotherapists. And so basically the intervention group, the movement system impairment exercise group, they got evaluated on a whole bunch of parameters. So here are some of the tests that they did. They did standing posture assessment, looked for asymmetry and regularity of the lumbar spine. They looked for posture type and shape of the lumbar curve. They did posterior pelvic tilts against the wall. They did forward bending to measure lumbar flexion, lumbar extension, and relative flexibility of different parts of the spine. They corrected the forward bending and noted whether that had any effect on symptoms. They did the return from forward bending. They looked at the timing and the relative contribution of their hip extension, their lumbar extension, their pelvic and shoulder movement. Then they corrected that and saw and measured whether that had any effect on symptoms. They did sitting, looked at different sitting postures. They looked at knee extension in sitting and looking at whether that caused the lumbar spine or the pelvis to rotate. They did supine, lying on their back with knees flexed, knees extended. They did lying on the back with knees bent with hip abduction and looked at their hip flexibility. They corrected their hip abduction. They lay them prone, looked at their relative flexibility between their knees and their hips. They corrected that. They looked for asymmetrical pelvic rotation. They looked for hip rotation, relative flexibility between hips and asymmetrical pelvic rotation. They looked at hip extension. They looked at quadruped, so on all fours. They looked at the lumbar alignment, any asymmetry or any alignment of the hip joints. They corrected that and then measured for symptom change. They lifted the arms and looked at the spine when the arms were lifted, when each arm was lifted, whether there was asymmetrical lumbar spine movement. They rocked back and forwards on all fours and looked at their relative flexibility between the hips, the shoulders and the spine and the pelvic rotation or tilt. Then they corrected that and measured symptoms. So it was a very comprehensive assessment. And for each of the items, I'm reading here now from the study, the participants assumed a position or performs a movement and reports the status of their low back pain symptoms. So symptoms either increased, decreased or stayed the same. Positions or movements associated with increased symptoms are followed by corrected alignment or movement involving minimising the lumbar movement, that's the low back movement, that occurs in the early part of the range of motion, or that is excessive, in the opinion of the physiotherapist, while increasing movement in other joints, i.e. the hip joint. An improvement in the symptoms indicates that the movement or alignment impairment in a specific direction, i.e. extension, is associated with the patient's symptoms and helps to decide on the participant's movement system impairment classification. For each of the items, the examiner judges the alignment of the lumbar region in different positions and or looks for incorrect timing and or magnitude of lumbar movement during trunk and limb movements. Alignment of lumbar region in a specific direction in different positions and incorrect timing and or magnitude of lumbar movement help to decide on the participant's movement system impairment classification. And relative flexibility refers to motion of adjoining segments occurring more readily in one of the joints. So, for example, if the lumbar spine moves more easily than the hip joint, even if the motion should be occurring in the other joint. In general, if patient exhibits a relative flexibility impairment, if the lumbar region moves in the first 50% of the ranges of the overall movement or excessively during the overall movement. So that is, it's a very in-depth classification and physical assessment. And then the treatment group got basically exercises targeting those impairments that were identified. So they got exercises to correct their flexibility imbalances, their movement control imbalances, their asymmetries, etc. And the other group, the general exercise group, got symptom-guided stretching and strengthening exercise. So they got everyone in the group got the same program. It was basically just spinal exercises, spinal flexion, spinal extension, spinal side bending and spinal rotation. They got hip flexion, hip extension, hip rotation, hip abductors and hip adductors. So they just did static stretches for each of those for 30 seconds. And if that made their symptoms worse, they discontinued that particular stretch and then tried it again later. So basically that's what they did. So one group basically just got the same, and then they just got some basic strengthening exercises for abdominals and the back muscles. So they basically did 3 sets of 10 reps of, abdominal curls and stuff like that. And so at the end of the trial, what they found was, and I'm just going to read from the conclusions here in the abstract, Results. There were no significant between-group differences for the primary outcomes of pain intensity at 2 months and disability at 2 months. There were also no statistically significant differences between treatment groups for any of the secondary outcome measures. Conclusions. People with chronic low back pain had similar improvements in pain, disability and global impression of recovery, with treatment consisting of symptom-guided stretching and strengthening exercises and treatment based on the movement system impairment model. So that is an example, and there are many others, of a study that has looked at the idea of imbalances or compensations and done an intervention, Freudian slip, I said invention, an intervention to, quote, correct those imbalances and compensations, and found that it works no better or worse than just doing some general strengthening and stretching exercises. And that finding is extremely robust in the literature. It's been very well replicated. And I'd say it's pretty uncontroversial amongst researchers, and is enshrined in just about every clinical guideline around the world, that general exercise is just as effective. So in other words, just a general strengthening and stretching program is just as effective as specific exercise that targets, improving some parameter of movement, whether it's muscle activation or posture or alignment or whatever it might be. So basically, are compensations a thing? Yes, they are, but not the way that people generally think about them in the Pilates and possibly the physio world. And generally, compensations are actually a good thing if you have a body part that's not working properly because it's damaged or injured or grew up weak or is asymmetrical or whatever. Well, congratulations, not a problem. We've got multiple backups, so your other body parts can take over. Yay for you, that's awesome. And secondly, we have this kind of not quite clear definition and not factual definition of compensations mostly in the Pilates world, I think, where we see it's a deviation from some kind of idealized optimal biomechanical, scenario, and that any deviation from that is a bad thing because we're using too many of one muscle and not enough of another muscle. And what we find is that is just not the case. So hope that answers your question and puts that to bed for you. Sarah says, "Hey Raf, are the breathe education courses internationally recognised?" Good question, Sarah. How do I answer this? Here's the thing. Pilates itself is not internationally recognised. So there are companies out there, claiming that, our training is internationally recognised. And the reality is, that's kind of all Pilates is allowed in every country just about. So there's no such thing as internationally recognised because there's nothing that's unrecognised. So for instance, if you are living in the US and you want to go teach Pilates and you're qualified through Breathe Education in Australia, assuming you've got a green card and all of that stuff, you can just go get some insurance with the whatever the biggest insurers are over there, the normal, top 5 insurers that insure Pilates instructors. You can just rock up with your Breathe certificate and get your insurance and start teaching, and it's 100% legal. If you're in South Africa, you can do the same. Through Europe, you can do the same. The UK, you can do the same. Southeast Asia, the Middle East, you can do the same. And that's not because Breathe Education has some kind of magical, mystical international recognition. It's just because Pilates is like such a small, tiny thing in the eyes of most governments that it's not even worth recognising or not recognising. It's just kind of beneath their notice, so they don't really care. And basically anyone with any Pilates qualification from anywhere can teach Pilates anywhere. So, is our course internationally recognised. Well, recognised by whom? No one cares. There's no one to recognise it. It's beneath their attention. But if by internationally recognised you mean with a Breathe certification, can you go work somewhere else in the world? Sure. You go work anywhere you want. You just got to get yourself the appropriate visa and work permits and insurance, which you can obtain easily in terms of insurance with your Breathe certification, and go for gold. It's not like sort of something like physiotherapy where, if you're qualified in India, you might have studied 4 years and be highly qualified, and then you come to Australia and they make you go through the whole 4-year degree again, because Australia doesn't recognise that particular certification. So it's not like that in Pilates, because it's just kind of considered not important enough to worry about. All right, so I hope that helps, Sarah. Mary says, "Hi Raf, I'm loving AMA. I found it so interesting and look forward to it every week." Well, I'm really happy to hear that, Mary. Thank you. Thank you for being so generous with your time. My pleasure. My question is about lateral pelvic tilt. What causes it and how do I fix it? I would say I have a few questions for you which are kind of rhetorical and kind of also for you to answer for your own self. Well, the first question is why do you want to fix it? All right, no. Let me back up and ask a previous question. How do you know you've got lateral pelvic tilt? Because there are, if you've been told by somebody who stuck their fingers on your bony landmarks in your pelvis, like your iliac crests or your ASIS, your anterior superior iliac spine, the bony bump in the front of your pelvis, or your PSIS, your posterior superior iliac spine, the bony bump at the back of your pelvis next to your sacrum. If they palpated, which means to just touch those body parts and then kind of squinted at eye level and said, "Oh yeah, I think your left's a bit higher than your right," or vice versa, then they were probably wrong. And there are several reasons that I say that. The first one is that pelvises are not symmetrical. So in just the same way as when you go and get yourself measured for a pair of shoes, it's very, very likely that one foot is larger than the other. And almost everybody is slightly asymmetrical in every body part. So it is with our pelvises. So there's one particular study where they got a bunch of pelvises from cadavers, people who donated their bodies to science, and they stuck these pelvises in a special jig, which is just basically a set of clamps that clamp it in a very specific position. And then they measured the relative height of all of these bony landmarks, the ASIS, the PSIS, the height of the iliac crest, the pubic symphysis, etc. And what they found was there's about a plus or minus 11 millimetres in most of those in terms of height from side to side. So if your ASIS is 11 millimetres higher on one side, that doesn't necessarily mean your pelvis is tilted. It might just mean that your actual ASIS is 11 millimetres higher and your pelvis could be perfectly level. So that's one thing. So there's a bunch of studies showing that pelvises are, and all other body parts, are in fact not perfectly symmetrical. So if we made you line up your ASISs so they were perfectly in line, that might cause you to be in a laterally tilted pelvic position. The second thing is that it is highly unreliable to palpate these bony landmarks and determine where they are. So there's a bunch of research looking at trained physiotherapists, so very experienced physiotherapists, 20 years average experience, all palpating, certain bony landmarks in the spine or pelvis, and basically wildly disagreeing about the location. So they'll all be like, "Oh, I've found the right L4 transverse process," or whatever. "I found it. It's here. No, it's here. No, it's here." So they basically can't agree on that with, obviously none of them think it's on the shoulder. They all, very fairly close to each other, but they might be out by a centimetre or so. So if you think trained physiotherapists who do this for a living and are very confident that they're doing it correctly can be plus or minus a centimetre with their palpation. And then we stack on top of that the fact that the actual bony landmarks vary in their position by plus or minus a centimetre. Well, you can be out 2 centimetres in either direction. So there's a 4 centimetre variation there in the normal pain-free population. So, just because someone looked at you or palpated your bony landmarks and said, oh, your XYZ is lower or higher than your other side, it's very unlikely that they're correct. So that's number one. How do you know you've got a pelvic tilt? You probably don't, unless you've had an X-ray or a CT, which has been measured, not just eyeballed by somebody. And second question, okay, just say you do know you've got a pelvic tilt. Well, how do you know it's causing a problem? Is it causing a problem? I mean, do you have back pain? Do you have hip pain? Do you have sacroiliac joint pain? And if you have back pain or hip pain or sacroiliac joint pain and you have a pelvic tilt, well, how do you know that the pelvic tilt is causing the back pain or the hip pain or sacroiliac joint pain? Because the assumption that it's causing that pain is not necessarily the most likely explanation. And that has been shown, again, by, for example, the movement system impairment research that I mentioned in the last question or the previous question before that when we correct these asymmetries, the pain doesn't get better any more than when we just do general exercise. So there's something about exercising that helps pain, but whether we change specific things or not doesn't seem to be important in terms of alleviating pain, disability for people with low back pain and sacroiliac pain and whatever. So how do you know you've got a lateral pelvic tilt? You probably don't know that, even if you've been told it with a great degree of confidence by somebody who should know. They probably don't know. Second, if you've got it, how do you know it's causing a problem? Do you have pain? If you don't have pain, it's not causing a problem. If you do have pain and you've got a pelvic tilt, how do you know the pelvic tilt's causing the pain? And the answer is you can't know that. And the reason you can't know that is because pain is multifactorial and complex and is basically generally not possible to distill it down to a simple, A caused B. When it comes to pain, it's highly complex and not well understood. But what we do understand about pain is enough to say that it's generally multifactorial. If you have pain, if you have low back pain, if you have hip pain, if you have sacroiliac joint pain, the things that I would recommend, don't worry about your pelvic tilt. Do some general exercise, strengthen whole body, stretch whole body. Doesn't matter what exercise you do, just do something you enjoy. Get enough sleep, get 8 to 9 hours a day sleep. The best way to get more sleep is to spend more time in bed. Spend more time in bed, you're likely to spend some of that time asleep. Manage your stress, remove yourself from stressful situations or do things to manage your stress. Meditate, go for a walk in nature, have a glass of wine with your loved one, do some exercise. Empower yourself with some fearlessness about movement. And, I'm trying to do that. I'm trying my best to help you with that right now by trying to help you understand that it's extremely unlikely that there's any problem with your pelvis. Your pelvis is probably awesome and perfectly fine and works perfectly. And that the problem, if you have pain, and if you don't have pain, hey, happy days, just walk away, don't worry about it. But if you do have pain, it's probably more to do with a sensitized nervous system and an oversensitive pain system rather than it is to do with a dysfunction in your pelvic geometry. Asterisk, if you have pain and you recently had a fall, well, yeah, that might be related. You might have some bruising or whatever. But, from the sounds of what you've written, that doesn't sound like it's the case. So I hope that helps. Get moving, check if you're getting enough sleep, manage your stress, and try not to worry about it. Hope that helps, Mary. Genevieve says, hey again, Raph, hope you had a good week. I did. I had an awesome week. Thank you very much. Just a small niggly question on the rectus femoris, which is the straight muscle of the femur. It's the central muscle in the front of your thigh, one of the quadriceps. From the anatomy of the knee lecture, what I understand is that in standing, hip flexion, then knee extension. So in other words, when you stand up, you lift your leg up and then you straighten your knee. So your leg is straight out in front of you. This movement, it shortens the rectus femoris across the hip and the knee joint, because the rectus femoris is a hip flexor, so it flexes the hip, and it's a knee extensor. It's one of the quadriceps, so it extends the knee and flexes the hip. That's correct. Thus, the burning and difficulty of this position and the muscle pulling from either end. Is that right? 100% spot on. You've got it, Genevieve. So when we see yogis or dancers standing and lifting one leg straight up in the air with the knee straight, is this something that can be progressively worked on, even though it is always going to be shortened across the two joints, or are some people just genetically able? Thank you, Genevieve. Genevieve, so I think it's a little bit of both. So the ability to lift the leg up involves working the rectus femoris at very short muscle lengths. And there are also other hip flexors that are working there. So the psoas, the iliacus, the tensor fasciae latae, the sartorius, the pectineus, adductor brevis, adductor longus, they're all going to be working in that hip flexion movement. So even though the rectus femoris, is working really hard at a very short length and thus probably not producing a lot of force, the other muscles can compensate and make up for the difference. So, having a stronger psoas and a stronger, all the rest of those ones can, make up for the lack of strength that the rectus femoris can produce in that position. So, and how do you get a stronger psoas and a stronger adductor brevis and whatever? Well, you practice movements that strengthen the psoas and the adductor brevis. What's a movement? Well, a movement like standing, lifting a leg straight up forwards, where the rectus femoris can't contribute because it's maximally shortened and can't produce a lot of force in that position, will force the psoas and the pectineus and the iliacus and the blah, 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 all the other ones, to work harder, which will in turn strengthen them. So in other words, just practice doing the thing and you'll get better at doing the thing. So that's part of it. So yes, it's called a length-tension relationship. And as muscles are very short or very long, they produce less tension. Whereas in their mid-range, muscles are much stronger. The other thing is that as you lift the leg up, you're lifting against not just the weight of the leg, but you're also lifting against the resistance of the muscles and tissues on the back of the leg. So your hamstrings, the fascia, tendons, etc. at the back of the leg have to elongate, and if they're stiff, and by stiff I mean a very specific thing. I mean resistant to length change. So when you pull on it, it is hard to lengthen it. You have to apply a lot of force to lengthen it. Well, if things require more force to lengthen, well, you have to apply more force to lift your leg up, right? So actually you want less stiff muscles, fascia, tendons, etc. on the back of the leg, and stronger muscles on the front of the leg, but particularly stronger at short muscle lengths. So the final two things I'm going to leave you with are, how do you make muscles less stiff? I'm not aware that there is a way. So I'm just going to leave that there. How do you make muscles stronger at short muscle lengths? Well, strength is joint angle specific. So when you practice strengthening at short muscle lengths, you get preferentially stronger at short muscle lengths. So doing like general hip flexor strengthening won't be anywhere near as good for this particular application as strengthening in the exact position that you want to get better in. So it comes back to get better at doing the thing, do the thing. And then probably choose the right parents and have, low stiffness in your passive tissues on the back of the hip. Hope that helped, Genevieve. Karen says, hi, Raf. If someone has had a herniated disc or microdiscectomy, which is just where they shave off a bit of herniated disc, herniation, as we said in the hiatus, hernia is where a part of an organ protrudes in or out of some body cavity, and a herniated disc is a disc in your back in between two spinal bones where the disc bulges out, herniates out into the spinal canal or some other part of the body. And a microdiscectomy is where they just basically slice off the bulging bit. So if someone has had a herniated disc or microdiscectomy a few years ago and no longer has pain, are there any restrictions on what they can do? How long after they feel okay can they do flexion exercises? Thanks, Karen. Well, Karen, the statute of limitations on discs is about 12 to 18 months. So, and that is because the discs are made of something called connective tissue, and the healing time for connective tissue is about 12 to 18 months. So, if you cut your finger, the skin will heal in a couple of weeks. If you tear a calf muscle whilst running, that'll heal in like 3 to 6 weeks. So if you break a bone, that'll heal in about 6 weeks, depending on which bone it is, but 6 to 8 weeks-ish. And so there are, known kind of ranges of how long it takes various tissue types to heal. And connective tissue, which is the tissue that forms your spinal intervertebral discs, as well as your ligaments, as well as your tendons. Another name for it is fascia. As your Achilles tendon, for example, your rotator cuff tendons in your shoulders, your anterior cruciate ligament in your knee are all connective tissue. And all of those things take roughly 12 to 18 months to heal. So if you, rupture your Achilles tendon in your ankle, you would expect to, take 12 months to get back to basically, almost full strength. Same if you have an anterior cruciate ligament surgically repaired in your knee after you rupture it. It's about a 12-month rehabilitation process. So that's what I would expect in a herniated or microdiscectomy disc. So I would say for the first 12 months, you should gradually build load. And with all of these injuries that I referred to, so if it's an ACL rehab in your knee, or if it's a Achilles tendon tear, or any other ligament or tendon injury, initially, immediately after the injury / immediately after surgery, what you want to do is, for a short period of time, protect that tissue from load because it's just got a few sutures holding it together. But very quickly, like within a week, you want to start to load it very gently and gradually, progressively load it more over time. So it's not a case of stay off it for a year until it's healed, then load it, because actually the healing is facilitated by loading. The healing process, so all of these tissues, connective tissue, are made of primarily collagen, which is a protein that is secreted by connective tissue cells that live inside the structure. And so the collagen is a fiber, think like carpet fibers, right? And it's just protein, like hair. Hair is a protein. It's not collagen, but it's similar, but it's unlike hair. Well, it's like hair in many ways, but it's just way smaller, like, several orders of magnitude smaller, narrower than hair, but otherwise similar. And so these collagen proteins are secreted. When you have an injury to your tendon or your disc or whatever, the cells in there, the connective tissue cells, start spewing out collagen to remake that tissue, and they spew out collagen, but it just all goes it's just a big pile of collagen fibers all mixed up together. And then as you apply load to that tissue gradually over time, the collagen fibers align themselves in line with the forces that are applied to the tissue. So if you gently load your injured Achilles tendon, it stretches the tendon in the way that the tendon is normally used. It stretches it out, and the collagen fibers start to align themselves along the lines of force that are transmitted through that tendon. And now when the collagen fibers are aligned along the lines of force, they provide greater tensile strength. They resist being pulled apart more when they're aligned along those lines of force. So applying load during the healing process is a crucial part of the healing process. If you don't apply load, the collagen stays disorganized, it doesn't line up. And after kind of that 12 to 18-month healing window, it's called the remodeling phase in high-class language, that's when you have the opportunity to realign that collagen. After you've past that, it's much harder to remodel that collagen in response to load. It can still be done, but it's not as responsive once it's fully healed. So the optimal thing would be, very soon after surgery, you would start gently loading, whether it's an Achilles tendon or a ACL in your knee or a disc in your back. And then gradually over 12 to 18 months, you would progressively load it more and more till by the 12-month point, you were fully, probably even by the 6-month point, you were fully loading it. So, because even full load is like, think of like doing loaded sit-ups with a kettlebell, or doing the hundreds on a reformer with 3 full springs, right? I'm talking load. Even full load is nowhere near what's going to happen, what that tissue has to deal with in an unstructured situation. So just imagine you're playing sport and you're running and someone tackles you from the side, right? So some kind of unexpected explosive, situation with contact or falling or twisting or whatever. It's like that's what the tissues have to be able to deal with. So that's what they have to be able to deal with by the end of the healing process. So by about halfway through the healing process, they should be capable of, dealing with full normal strength under controlled conditions. So for instance, if you're rehabilitating an anterior cruciate ligament, 6 months into rehabilitation, you're not ready to go back to playing football, but you are ready, or you should be ready if you've been doing your rehabilitation properly, to do hopping and, one-legged squats with a barbell. Like you should be doing strong work. So for your client, Karen, who had a microdiscectomy a few years ago and has no pain, I would say just treat them like somebody who hasn't flexed for a while, if they haven't flexed, and just start easy and build slowly. And just treat it like, building up strength in their back, basically, building up strength in their abs, increase over a few months until they're working up a really good head of steam and, doing super impressive moves. And if they don't have any pain, I would just never mention it. I wouldn't ask, how's your back? I wouldn't say anything about it. I wouldn't mention pain. Just make it not a thing. Talk to them about other things. Keep their mind off it. Focus on how many more reps do you reckon you can do. Great, you're doing awesome. High five. So that's what I'll recommend. Hope that helps, Karen. Kira or Kyra. Apologies, I'm not sure how to spell it, how to pronounce it, Kira or Kyra, because I've interacted with you quite a bit, but only in written form. So I apologise if I've butchered the pronunciation of your name. Hi, Raf. I have a question for you. I hope you find it slightly interesting. Apologies for the long explanation. When I jog or do too much physical exercise in general, my right knee gets uncomfortable or flares up. Both knees naturally roll inwards or medially, my right worse than the left. Do you know if knee rotational position contributes to this issue? Particularly when I run, I try my best to stop them rolling medially, as this was the advice I was given when I was younger from a physio. But I'm starting to think this could actually be the problem. Should I just let them be? After all, this is how my body was built. I was literally born this way. Your recent talk on posture got me thinking about it. Thanks for your awesome and critical thinking, Kyra or Kira. My apologies for getting that wrong one way or the other. You don't say where the pain is in your knee, but basically regardless, the prescription of exercise is going to be pretty much the same. So there is a place for changing your movement strategies sometimes. So if you have pain that hurts when you do it one way and doesn't hurt when you do it the other way. So if, like, for instance, when you run, you have pain, and if you turn your knees out, the pain magically disappears. Well, I'd say there's an argument for turning your knees out. But if you've been trying to do that for years and it still hasn't taken and you still have pain, it sounds like it's not really probably doing that much. And it's really, I would really use a biomechanical change like that, turn your knees out, as really just a kind of a temporary get out of jail free card whilst you strengthen up the area. So people run with all kinds of weird and wacky alignments, gaits and positions at all kinds of levels, like including elite runners. So it's very unlikely to be the case that your alignment is, quote, causing the pain, although it could well be that you've become sensitized to a particular position, and so thus changing to a different position that you're not sensitized to might alleviate the symptoms. But that's not to say that the new position that you're not sensitized to is the, quote, correct position and the old one was the, quote, incorrect position. It's just that, like, you've become sensitized to that position. Like Steve Martin in Dead Men Don't Wear Plaid, the classic 80s detective spoof, where he's got a thing where if anyone says the word cleaning lady, he goes into this psychotic fit and starts murdering people. And so he's sensitized to the words cleaning lady. And so if you just don't say cleaning lady, well, the issue doesn't happen. And so that's kind of, what might happen with, but there's nothing actually wrong with cleaning ladies. Cleaning ladies are fine. That's not their fault. They didn't do anything. And probably, could be the same with your knee, that it's, turning medially is not a problem. It's just that maybe you've become sensitized and the sensitization has been associated in your central nervous system with that position, and thus choosing a different position might help. But it doesn't sound like it's helping to me, because you've still got the issue, right? Even though you're, diligently turning your knees out. So the general prescription for knee pain, which in high-class lingo is called patellofemoral pain syndrome, and there's a hint there when we call anything is called a syndrome and simply describes the symptoms. So patellofemoral pain, patella is the kneecap, femur is the thigh, so that patellofemoral is like somewhere in your kneecap and your thigh. Pain syndrome just describes you've got pain in your knee somewhere. So any kind of diagnosis that simply describes the symptoms gives you a big heads up that we have no clue what's causing them. But their exercise is quite effective for patellofemoral pain, and the best combination of exercise is hip strengthening. And I'm not just talking about glutes, I'm talking about every muscle in the hip. So hip extensors, glutes and hamstrings, hip flexors, your hip flexors, hip abductors, hip adductors, so just everything in the hip, plus knee strengthening, so quadriceps, hamstrings and calves, because the calf muscle also crosses the knee. So in other words, strengthen the whole leg. But for some reason unknown to science, if you start with hip strengthening, so start by focusing on hip strengthening, and then a few weeks in, 3-4 weeks in, add in the rest of the leg, knee and calf and all of that. That will probably give you better results. So I would start with things like glute bridges and side leg lifts and leg raises and knee squeezes and side crab walks and things like that with a band around your knees to strengthen up the hip, the inside, the outside, the front and the back of the hip. Once you've been doing that for a bit, then keep doing it and add in whole leg work, lunges, squats, footwork, sideline footwork, legs in straps, all of this stuff just to strengthen everything in the leg. And then I would just advocate a graded exposure approach. So basically run as far as you can run with tolerable pain. If you get a bit of pain when you run, I wouldn't worry about it. If the pain settles within 24 hours after you finish your run, it's fine. If it doesn't settle within 24 hours, then do run less distance next time until you find a distance and a pace that will enable you to run and for your symptoms to settle within 24 hours after you run. And then do that for a few weeks and then see if you can push the envelope a bit, see if you can run a little bit further and see if the symptoms will settle within 24 hours still, and just keep doing that. Just basically keep gradually pushing it, keep doing your strengthening of your hip and all of the leg muscles. So hope that helps. And thank you all. That's all we've got for today. Hope you found that useful. Hope you found it interesting. This is released as a podcast now, so you can find it on your iTunes, your Spotify or Google Podcasts or any other, wherever your favourite place to find podcast is, as an audio-only podcast. Or if you're already listening to this on podcast and you want to see my gesticulations and a couple of little stick figure drawings, you can head over to YouTube and find us on YouTube and watch the video. So I hope you find that helpful. If you want to send me a question, just email me, Raphael, RAPHAEL, .B for Bob, at breathe.edu.au, and send me a question. You don't have to be a friend, you don't have to be a client, you don't have to be a student, you don't have to know me from a bar of soap. If you've got a question, send it in. I'll do my best to answer it. Hope you're well. Hope your loved ones are well. See you next week.